Hi, good morning or good afternoon, depending on where you're logging in from. We are going to get started in about 2 minutes. Thank you.
Okay.
Hi, good morning, good afternoon. We are going to get started in 1 minute. We are going to ask that you please mute yourselves and we'll get started shortly. Thank you.
Have you muted yourself on the phone?
If you press *6 on the phone, you will mute yourself.
Something.
Okay, we are going to get started now and we will continue to let people into the training as they log on. But out of respect for our presenters' time, we're going to get started right now. Thank you all for joining us so much. My name is Janice Davis and I'm the Age Friendly and Health Equity Program Manager at Urban Health Partnerships. And today we are starting our second week of this year's Age-Friendly Public Health Systems 4M training for healthcare practitioners. And this week's training is all about the patient side of the 4M framework. And we have 3 dynamic speakers today, Leslie Pelton, Alice Bonner, and Diane Moriani, and they will be introduced shortly. For our objectives for this week, they are to understand why it's important to look at the interdisciplinary team for the age-friendly health system framework and why it's extremely important to align medical treatment with what matters most to the patient. This is our second week. For those of you who joined us last week, you know that we had a dynamic social worker from Kaiser Permanente Hospital out in Hawaii talking about how social workers are very important to the 4M framework. And this week, we are very honored to have Dr. Alice Bonner, Leslie Pelton, and Diane Moriani to talk about the patient side of the 4M framework. And I am going to turn it over to my colleague, Isabel Edrande, to introduce our dynamic speakers for this week. Isabel?
Hello, everybody. I'm Isabel. I'm the Health and Livability Project Coordinator here at UHP, and I'm very excited to introduce the 3 speakers that we have today. Janice, can you get to the next slide, please? First, Leslie Pelton and Alice Bonner are going to talk about prioritizing what matters most to the patient, and then Diane Moriani is going to talk about the importance of focusing on and supporting caregivers. Next, please. So for the first part, I am very happy to give a brief bio for our 2 speakers. First, we have Alice Belton, who is an outcome-oriented leader who catalyzes innovation in health systems and transforms passion into impactful action. Throughout her 24-year career, she has brought these talents to the improvement of health and healthcare of adults of all ages and community, healthcare practice, hospital, and nursing home-based care. Ms. Belton is a nationally recognized recognized leader in the age-friendly health systems movement. With funders, national partners, leading health systems, and the IHI team, she designed the campaign that has resulted in improved care of older adults in 1,000 places of care across the US. And then we have Dr. Alice Bonner, who has been a nurse practitioner for over 30 years. She's currently adjunct faculty and director of strategic partnerships for the Johns Hopkins University School of Nursing Capable Program and senior advisor for aging at the IHI. Dr. Bonner received an AB from Cornell University in 1979, a BSN from Columbia University in 1981, and MSN from University of Massachusetts Lowell in 1989, and a PhD from the University of Massachusetts Graduate School of Nursing in 2008. From 2015 to 2019, Alice served as Secretary of the Executive Office of Elder Affairs for the Commonwealth of Massachusetts. From 2011 to 2013, she served as Director of the Division of Nursing Homes in the Centers for Medicare and Medicaid Services in Baltimore, Maryland. Her research interests include home and community-based programs, nursing home quality, nursing workforce development, preventing and ending elder mistreatment, and preventing and ending homelessness in older adults. Please join me in welcoming Ms. Belton and Dr. Bonner.
Thank you, Isabel, and hi, everybody. It's great to be with you today. Apologies from Leslie Pelton, who was not able to actually join in person today, but she and I worked together on this presentation. So with that, I am going, it says it's going to stop other screen sharing. Is that okay, Isabel? Okay. In that case, I will then share my slides. It takes a moment for that to come up. So if you just wait one moment while it goes to black. Okay. So again, very glad to be here with everyone. And I am going to provide, I hope, a brief overview of age-friendly health systems. I know you should be able to see the slide. Can you see it, Isabel? Yes? Okay, and I will, because I really want you to hear Diane's presentation. I work with Diane on a number of projects, and she's got great point of care and research expertise to share with you. So I'm providing some background information. For some of you, this may be really new. For others, you may do it every day. And so we're gonna try to present information that's helpful to all of you. And you can go back in the slides and go over them in more detail, or contact me and I'll be happy to share more along the way. So again, I already said that we're going to do these things. We will give some examples of implementers and a little bit about personal stories that I hope you all will share along the way. And you know, All Teach, All Learn, I imagine some of you may have been involved in Project ECHO from the University of New Mexico, which is a real standout for All Teach, All Learn methods and networks. So I'm happy to talk more about that. So a couple of thoughts on what might be some takeaways for today. So, you know, that age-friendly health systems and communities provide a framework for quality improvement for people of all ages. You know, we're talking about older adults, but it's really a framework that works for everyone. And it's based on what matters to older people and to communities and to public health. Interprofessional teams are critical to age-friendly health systems. And again, I imagine almost everybody on this call, maybe everybody works with interprofessional teams. And, you know, for this particular presentation today, we're focused on the older people themselves. And sometimes we call them patients. Sometimes we call them residents if they live in a nursing home. Sometimes we just call them people. And those are the ways people want to be referred to. So it's important that we listen to everyone, and we'll talk more about that. So again, I hope this graphic is familiar to many, if not, you know, most of you, that, you know, this is the 4M framework for age-friendly health systems. And it basically says that this is a movement, a social movement, so that all care with older people is equitable, age-friendly care. And you can see here that means it's guided by a set of evidence-based principles, what we call the 4Ms, which you can see here on the graphic. It causes no harms, and it's really consistent with what matters to the older person. You can also see that we had an aim here because, you know, IHI and our partner organizations are all about putting a bold aim out there And we'll talk more about that. As you'll see, we reached and exceeded that aim. So wanted to give, certainly give credit to the John A. Hartford Foundation. They are funding a lot of this work, maybe some of you as well in the audience, and the American Hospital Association, Catholic Health Association, and many nursing home associations now, so across all healthcare settings. Very busy slide to demonstrate that we have lots of organizations involved. So, if you don't see your own organization's name on here, it's because we kind of ran out of room on the slide, but many more than just depicted here are engaged in age-friendly health systems. So this slide just shows you, if you're wondering, like, how did they come up with the 4 M's? It was a pretty detailed process involving a number of pioneer health systems, 5 systems with lots of national experts. And from an initial set of 90 care features from the literature, those were culled down to about 13 features, and then down to the vital few, which are the 4 M's. But there was a lot of work that went into that. And so, each of the 4 M's is described here on the slide, what matters: medication, mentation, which includes dementia, delirium, and depression, and mobility. And, we tweak this language, local sites tweak the language a little bit, but this is essentially the framework and kind of the basic standards of age-friendly care. And the 4 M's are a set. And I think that's really important that everybody thinks about the 4 M's, even though we divide them up and talk about each of them distinctly, they really come back together as a set. So how do we deliver 4 M's care? Well, there's actually these 2 key drivers of age-friendly care, and it's that we assess, we screen and assess, and then we act on what we find in the assessment. And so that act on is really critical. That's where we have interventions and things that we actually do to make a difference and deliver age-friendly care. We don't just document that we've figured out that someone falls into the category for receiving age-friendly care. The other thing that we do a lot of, and some of you are contributing to this as well, is we try to publish and promote engagement, and we try to get people motivated to take action and to come along with us and to do these things together. So this was a recent publication. There's many others that you can find, and we'll talk about some other ways that we share the information as well, and that you do. So in addition to sharing the information in the scientific literature, which I just showed you, how are we going to do this with the public? How are we going to make it clear that every one of us should demand age-friendly care? It's what we all deserve and we don't always get. So what are the ways that people receive and learn information? And, it's about everyone learning the information. This was a picture from, 6 or 7 years ago of myself and Nora Moreno-Cargi, who's at the Tufts Health Plan Foundation, with both of our mothers. And my mother was, has had Alzheimer's disease for a long time. She just passed away about a year ago. And Nora's mother had a bunch of physical challenges, and they got along famously. They had never, met each other before, but it was a very nice way of, thinking about people with cognitive challenges, people with physical challenges, and being really inclusive and making sure we're talking to all older people, regardless of their clinical or cognitive situation. So just in terms of some numbers, again, I showed you the bold aim earlier. Well, we have surpassed what we were shooting for, which was 2,600 organizations becoming recognized as age-friendly. We actually beat that about a year early. So we think that's good. But, when you think of the numbers of healthcare organizations in the country, we have 15,000 nursing homes and thousands of hospitals. So to me, this is sort of getting us to the starting line. We still have a long ways to go, but we have a participant level, which just says, you've put together how you're going to approach age-friendly care. And then we have this other aspect of committed to care excellence. And in the committed to care excellence, those are organizations that are actually sending data to IHI, and we sort of help with the measurement strategy. So lots of ways to participate. We try to keep the burden very, very low so that, there are things that you're reaching for and things that you're measuring, but your teams are not overly burdened by the work. And then in terms of, so that's the number of organizations. In terms of the older adults themselves, it's now over 1.4 million older people who have had 4 M's care delivered to them as a set. And you can see the t-shirts here from one of our partner organizations, and it just says, what matters to you matters to me. Simple statement, but it just says so much about every individual, person in the care force really doing this work. And then we have lots of quotes and testimonials as well. So this is an example for you of how IHI collects stories and structure about the ways in which healthcare organizations deliver the 4 M's. And again, some of you on this call, I hope you'll chat in if you are engaged in age-friendly health system work. I can't see the chat right now, but Isabel and Janice can, so they can call out some of your ideas. But this is an example of an accountable care organization in Maryland. And here's the 4 M's, and under each M, there's a very detailed, actually, this is sort of an overview, but even more detailed than this, there is a description of what they are doing with each of the 4 M's. And you can just see things like, they have a particular delirium assessment that they use, and they do exercises, and they do mobility contests for mobility and so forth. So these are all the ways that organizations structure their work. And we put this in the guide. So there's a guide for doing age-friendly health systems in hospitals, in nursing homes, in ambulatory practices. And then Anne Arundel did a really nice job of also looking at, so what were the outcomes? So they've got outcomes about readmissions and improvements in mobility. And then at the end of the implementation, they said, well, what did we learn from this? And we've heard a lot of feedback from multiple organizations that starting with the what matters as the first M is really helpful in structuring the rest of the process. And I'll talk more about the what matters in a moment. But, they also talked about IT and how engaging their IT team together with their clinical teams made a difference. And, showing that the progress was happening along the way and showing the trends in the improvement really made a difference to the direct care workers and the rest of the team. And it's not easy for teams to be patient along the way, but that's one of the learnings. So, how do you work with your team? How do you create an opportunity for people to really stay with you along the way? So, what was one of the other things that the Anne Arundel leaders did? And you may or may not have picked it up from the slides that I showed you, but they really cared about mentoring. And so, when you think about it, how do you find a mentor if you need a person to be your mentor? And how do you become a mentor if you're somebody who's got experience and wants to work with others? So, mentorship and leadership is a big part of age-friendly health systems, as it is a big part of a lot of the other work that many of you do every day. So sometimes people ask us, well, how will we measure the results? How do we know if age-friendly is making a difference? Very important question. And this is an example of a slide that just shows you, I know there's a lot on here, but there's a lot of different ways that we can measure things with existing surveys, with data that we have in different systems, in nursing homes, we have in the MDS, for example, and other ways. So again, we don't require a lot of data collection, but we do support and encourage people to look at the systems that will work for their own organization.
Alice, there's a question about those outcomes, and it's asking, can you explain more about the outcomes and the measures that you used?
So with this slide, or the outcomes with Anne Arundel?
Marie, can you unmute yourself to clarify for Dr. Bonner, please?
Well, hello, just the overall, with this slide, what measures did you use to particularly get these results? Because I know sometimes we have a hard time finding the proper measures to explain and find out if the 4 M's are working. So, and I like how you listed these process of measures, but if you could just give like a deeper example of like how you went in to get those measures and get those outcomes.
So it's a great question. And the short answer that we definitely have time for, and then I'd be happy to follow up with you and give you a more detailed answer, is that we really work with individual organizations because, different organizations already have an infrastructure with certain data platforms, databases, et cetera. And so we very often will try to start with, well, what do you already collect? How do you already look at some of these measures and where there are opportunities? We have quality improvement coaches at IHI, and they also have them at AHA and other organizations. And those quality improvement coaches are the ones who really understand these measures in detail and can help organizations set up. Like, people will say to us, well, you know, we ask about advanced care planning, but we don't really ask questions around what matters to you today, or what do you want to be able to do at the end of the week, and things like that. So again, we have guidance around how to structure those questions. And I'll show you in a moment one of the ways that we actually help people institute those questions for what matters, and then measure how often that they're being answered and documented and so forth. So if that's okay for an answer, and then we can.
No, that's perfect. That's
Okay.
awesome. I
Super.
really good. Thank you.
It's a great question. And the measurement stuff is one of the hardest parts of this. So I'm glad you asked the question.
Yes, it really is.
Yep, but good. So one of the other things that we try to do, again, this sort of relates to your question, is we want to help organizations figure out how to look at the business case. So we have on our website a whole bunch of free resources that, you know, if you are working with your CFO or your CEO, that you can show them. And there's things like the ROI calculator, return on investment. How do you know, if you're a hospital CFO, that you're not going to lose money on age-friendly health systems? Where are you going to save money? You know, what are the other aspects related to creating value? So value is, you know, the outcomes or the person's experience divided by cost. So there's lots of other resources there. So, you know, if we're working with populations and communities, how do we help them understand and demand age-friendly care? Because again, a lot of this is, I can't tell you how many times, and I suspect this has happened to many of you on the phone, someone will say to us, you know, my doctor asked me about what matters to me, and that was the first time anyone had asked me, or my nurse asked me what matters, or my pharmacist. But it's really common that people have not been asked in a way that they really understand. So again, here are the tools I was just speaking of. The Conversation Project is an incredibly helpful tool that is its own initiative. It's been up and running for 10 years. And we've got some links here for you. Please do take a look at these links. And there's a starter guide for how do you even begin to have a conversation with an older person. And then there's this What Matters guide that's put out by the Conversation Project. And it's not just about advanced care planning, as I said a few minutes ago, it's about current care planning. And some of the things that, you know, we were just discussing are, well, how do I ask these questions? And so there's really specific guidance, like, you know, in today's visit, I want to be sure we cover what's most important to you. You know, how often do I remember to say that as a nurse practitioner? I didn't always do it. I wish I had. Saying, is anything getting in the way of you doing the activities you would like to do? And that's important because it's the activities that are important to that person that should drive the care planning process and the actual care delivery. So how do we make meaningful change to a care plan? This picture, my father, who died 15 years ago, but, you know, still with us in spirit. And he loved being on the water because he had been a merchant marine and he loved fishing. And so if you didn't know that about him, how would you create meaningful change in a care plan around his mobility or around what matters to him? You had to know that. So it's that personalized, person-centered approach that really is such an important part of age-friendly care. The other thing is, some of you on this call may work in a nursing home, either in subacute or, you know, skilled nursing or in long-term care. There's a relatively new guide and workbook specifically for nursing homes and nursing home teams. And so we'd encourage you to take a look. It still says draft on this slide because we're still getting input from lots of people like all of you, and we want to keep making it better and better. So we'd love your input. And then finally, this is also a brand new tool. This is a book that Dr. Terry Fulmer wrote with Leslie Pelton. And it goes over from soup to nuts, everything about age friendly, and you can get it very cheaply online. So pulling it all together. So, you know, circling back to this notion of a public narrative, how do we get to the actual older adults and their care partners and communities and public health workers. And, we want to motivate people to come to action and come along with us. So we want to do all of these things that are outlined here, that people are equal in these conversations, that, we want to convey an urgency to act. We don't have any more time. We're out of time. We need to make these improvements and changes, and we need people to come along with us. And so, this is also, again, from this reference, a nice overview, I think, of how leaders make a difference, how they focus and can make a difference. So yes, they're going to have a vision and put it out there, develop capability, deliver results, but the center of that all it's driven by older people and the community. And then that's what shapes cultures across all boundaries. So again, how do we engage in the movement? We've got lots of information on our website, but we run action communities, which are peer networks. We can do scale up partnerships with individual organizations, and sometimes organizations just want to do it on their own. So there's a do-it-yourself pathway as well. And then, again, for the focus for today, so how do we engage older adults in this? Focusing on the community. Again, this is about public health. Many of you work in that setting. So, where and how can you find older people? And it isn't just about the local, organizations like the senior centers and the area agencies on aging. Of course, those are great places to find older people, but there's other places too, bowling alleys, hair salons, the bank, the grocery store. It's about bringing all of those things together and really engaging people. And I put what else as a question here. Chat in where else you have actually recruited older people for some of the work that you're doing as volunteers. So again, I put the same message up here today for takeaways about working with health systems and communities, interprofessional teams, and continuing to learn from older people. And so my other question to all of you is, what will it take for you to be the leader and champion of age-friendly health systems in your health setting in your community? And as part of that, how will you engage older people in the conversations? That second question is really important. How do you engage older people? It's not easy, by the way. I've been doing this for 40 years. It can be hard to find people, but it can be done. So yes, this is about you. This is for you to think about in your community, in your city and state. How will you make this happen? And I'll end this part of my talk with my two greatest mentors, my mother and father, who I wouldn't be here without them. Anyway, this is how you can get more information on the IHI website about Age Friendly and how you and your organization can get involved. So please take a look. And again, Janice and Isabel have my information and they can get in touch with me anytime. I'm happy to talk to any of you. We love getting more organizations engaged, and it's just super fun on the action communities because there's so much great sharing back and forth. Okay, now with that, before I turn it over to Diane, is there anything urgent in the chat or anything? Janice, go ahead.
Yes, you have a bunch of questions, Alice. So I'm going to start from the top and read the ones in the chat. And if there are other questions, I just ask you please raise your hand using the raise hand icon on your screen so we can keep track. But Alice, the very first question you got is, how can we get rural healthcare providers to understand the importance and long-term implications of the 4M model, and what has been successful for you?
Fabulous question. And you've identified one of the issues that comes up quite a lot, almost every week. We have had some success with organizations, and we are working with organizations in places like Wyoming, where it's very rural. North Dakota has a lot of interest in this, Montana. There are some rural areas in California and Western Maryland. So we do have rural areas that are engaged in trying to get age-friendly health systems up and running. I think a lot of it is the planning phase and getting the right partners together to be able to have the impact that you want. And so again, if you are in a community that's very rural, you're probably dealing with a lot of social determinants of health, a different transportation system, limited transportation, limited housing, longer distances to travel in between seeing older people. And so we do talk about all of those things. And sometimes other municipal organizations or state-based organizations can actually come together. We've done a lot of work with Habitat for Humanity, National Center for Healthy Housing, other housing entities that sometimes can come into the picture. So some of this is about, going outside the box and blowing up the older models, if you will, and saying, okay, this isn't just healthcare over here and the community over here. This is the integration, and how do we do that? So happy to talk more. And we have a list at IHI of all of the organizations that are involved in age-friendly health systems or have been recognized. And if you share where you are, we can try to put you in touch with some people who are in a geographic area similar to yours. Next question.
Next question is, how have hospitals increased patient mobility without increasing staff?
Great question. And the answer is they've actually done a lot, and they've done it by going outside of just saying nursing is going to, ambulate or increase the person's mobility. They've done a lot of work with PT and OT, with PT aides and CODAs. They've done a lot of work with activities or therapeutic recreation, which again, in the old days wasn't a big department in hospitals, but it's becoming more a part of person-centeredness. They've also engaged family members much more when they are appropriate and can be trained and can actually follow the recommendations. And they've also moved away from medications that have often impaired mobility or reduced mobility and caused sedation. So all of those things together have actually worked. And we have lots of hospital examples around mobility that we be happy to share with you, including some very nice ones from the VA. Great, next question.
Next question is, can you please share the 4M description survey? And that came from Magda. So Magda, if you want to unmute to clarify that question for Dr. Bonner.
Yeah, because we have a lot of surveys, so it would be great if you can say a little bit more about which one.
It's just that I work with clinics here in Miami, optional clinics that they used to be WellMed. So we are focusing obviously on it's like the model of the ACO, but in Medicare Advantage. So I would like to know, because we do the fall prevention, the depression, we do a lot of surveys just to comply with the HEDIS measures. But is there anything extra that we could do? Because I'm in charge of going to the community to speak to the patients, to the prospects, and independent living facilities, and see that they take care of their own health, because that's something that is non-negotiable, and that's something that unfortunately that's happening. They're negotiating with their health. So is there any other survey that we can create awareness, or I can do that meanwhile I'm out in activities and talking to people?
Mm-hmm. That's a great question. And I think the best answer for what we have right now is actually the guide to age-friendly health systems. And there's a guide for hospitals and ambulatory practices. Those are in one guide. And then there's one for nursing homes. But in that guide, there are appendices at the back that have, some of these surveys, and it has some of the questions, and it has a chart on, how to walk through each of the 4 M's and what's happening now and what's missing. And again, for example, a lot of hospitals say, oh, we do fall prevention. We have lots of fall prevention, which is great. Don't get me wrong. But that's not what mobility is. Mobility is much broader than just fall prevention. And so things like that can help. And the things about medications, the hospital will say, well, the pharmacist reviews the medications. Well, when you really dig down and look through each step of the process, sometimes there are gaps there. So I would just say, maybe start with looking at the guide, see if it's got what you're looking for, and then we can go from there. I think we probably would benefit from some more user-friendly flyers that are just like a one-pager, because your CEO isn't going to read more than a one-page flyer, right? Because they get them all day long.
I agree. Yeah.
Yeah. Anyway, I want to move on, Janice, because I have some other slides on the Capable program. I just wanted to go through, and I don't want to take Diane's time. So maybe we could, once I stop sharing my slides, then I'll be able to read through the chat, and I'll try to respond to the other questions as best I can, if that's okay with you.
That's fine. Thank you.
All right. Well, so Diane is going to talk about a lot of the different work that she's involved with, but one of the things is that Her organization is a local Capable site in Chicago. And Capable is community aging in place, advancing better living for elders. So we'll say Capable. And it's about older people being able to stay in their homes and community. And it's designed for people who have at least one activity of daily living challenge or difficulty. And it's really to treat the whole person and assess the fit between the person and the environment. And it really focuses on the older person being the expert. That is the person who should drive the processes and how they want to be able to stay in their own home. And the clinician, an OT or an RN, is just a guide in the process. And there are improvements in the person's function and self-confidence, and also some cost savings that you can learn much more about with materials, again, on the Johns Hopkins Capable website. But basically, Capable is 4 to 5 months, so it's a time-limited program. It's a registered nurse, an occupational therapist, and a handy worker. And that's the team that goes into the older person's home, and the older person sets 3 goals with the registered nurse and 3 with the OT. And then they work on whatever it is that the older person has identified as being most important to them. And in some cases, we have a couple of states like Colorado and Connecticut and Massachusetts, if you live in any of those states, that is actually getting ready to do this statewide through their Medicaid or other programs. Again, won't go into the detail on this slide, but there are publications, they're listed here, where you can read about where the cost savings occurred, and that it was sustained over 2 years. And it's quite substantial. It's about $20,000 a year plus additional to Medicaid. These are some pictures of some actual homes in Baltimore where the Capable program started. And as you can see, when those stairs on the right get wet and slippery, it can be a disaster. So lots of home repairs, holes in the floor and the closets, etc. This is just an example of a case, and I won't go into it in too much detail, but this woman's chief complaint was breathlessness. That's what bothered her. And so the Capable team went in and did all these interventions that made a difference and helped her pain and helped her mobility. And she got better and actually got to do the things she liked to do, like going out with her lady friends again. We have lots of testimonials. We have lots of feedback from older people about, how Capable really helped them. And we've got, pages of letters and things that people have sent to the program. And we have 40 locations around the United States, plus 5 research sites. So altogether about 45 sites. You can hover over the dots on our website on the map, and it's interactive, and it'll show you the name of the person running the program, so you could reach out to that person if you wanted to. So, why does Capable work? Well, we think that it's about the fit between the person and the environment. Older people being really motivated to improve, and just that support that people need for a short period of time to really get their self-confidence and self-efficacy back. And people do amazing things that they never thought they would be able to do, but they really are able to accomplish it. So this is our team, plus Dean Sarah Zanton, who was the creator of the program. But you can reach out to any of us, but please certainly reach out to me. And then we also included a slide with references, just so you would have all of those. So with that, I am going to stop sharing my screen, and then you will be able to move on to hear from Diane. And I'll keep looking at the questions in the chat. So Janice, back to you.
Okay, thank you so much, Dr. Bonner. I'm happy to introduce our next speaker, who is Diane Moriani. A licensed clinical social worker with a specialization in gerontology and a certified alcohol and drug counselor. Diane has over 15 years experience in program development and program management. She has co-written and effectively managed several SAMHSA grants during her tenure in the behavioral health field, culminating in sustainable family-centered treatment programs. In her current role as program manager, social work and community health at Rush University Medical Center in Chicago, Diane oversees the Rush Caregiver Intervention Program and leads the collaborative work of a model for caregiver health and wellness in age-friendly health systems planning grant. which is founded by the John A. Hartford Foundation to integrate caregivers into the age-friendly health systems movement. Welcome, Ms. Moriani. Thank you for being here today.
Thank you so much. I'm so on. Oh, yeah, I am unmuted. I'm so honored to be here, and I just delighted in your presentation, Alice. And I don't know if anybody was noticing me, probably not, but I'm just one of those head nodders. Like when I'm hearing something that I'm like that's resonating, I'm just nodding my head, and just so many things that we're just on the same page, and it's wonderful because we are collaborators, and just happy to be doing this work with Alice and the team at IHI. So I'm hoping you can see my screen, and I will tell you up front that I often have challenges with my technical skills here. So I hope they'll bear with me. I've been told that I shouldn't really divulge that, but I like to be authentic and let you know right up front what you got in store. So I am going to be talking about the importance of focusing and supporting caregivers. And something I heard, well, many things I heard, but one thing I heard from Alice early on was she said, listen to everyone. And it's really, that just kind of hit me for a second to say, really that's at the core, right? We need to be listening to older adults, and we certainly need to also be listening to those that are providing care and to our family caregivers, and the other part with that is not only, of course, we are listening, but sometimes we have to ask to be able to listen. So if we're not asking and we're not engaging, then, we're missing out. So I'm going to start with a quote from Ronnie Snyder, who is the Vice President of Programs at the John A. Hartford Foundation. And I love this too, because it connects the work with age-friendly and caregivers. And she has said, how can a health system truly be age-friendly if it doesn't address caregivers? And of course, we couldn't agree more, which is why we're doing the work we do. And I do want to recognize, acknowledge our funder, the John A. Hartford Foundation, for the scale and spread work that we're doing in conjunction with IHI, and also RRF Foundation for Aging, who does provide funding for our Caring for Caregivers or RUSH intervention for caregivers. And I want to just kind of give you an overview. You may have this information, this may be familiar to you, but in case it isn't, I do like to start here. This is from 2020. But it just gives us an idea of what we're looking at and what we're talking about with family caregiving. You can see that there's already in 2015, 43.5 million. And now you can see by 2020, the increase. And I'm sure now 2022, that's continued to go up. And then, nearly 1 in 5 unpaid care, are providing unpaid care to an adult with health or functional needs. And many are providing care for more than one person. And we've had, in our own experience, and then of course, statistically through these reports, many family caregivers are having difficulty coordinating care and are very challenged by the level of care that they have to provide. So we also know that there's more challenges when you're caring for someone with Alzheimer's disease or dementia. I think there's just additional layers to consider and, to be aware of, and it can be an additional burden and joy for caregivers. And so, it's statistically shown that there's just more reported emotional strain and physical strain for caregivers. And we have many caregivers in our program that also report their own poor health based on partly in their caregiving role, or their caregiving role possibly has intensified their health concerns. Part of that is they may be so involved with their caregiving role or managing their caregiving role and other roles that they're playing, including employment. Many of our caregivers are employed, that they're not really addressing their own health. So they're maybe missing their appointments. They're not keeping up with their own visits and follow throughs. And we are getting more information all the time about caregivers who are also employed and those that are losing financial strength because they're also having to either reduce work hours, take some leave time. Maybe they've given up a second job that they had that was helping them supplement their income. So we're seeing a lot of financial impact. And as you see here, 45% have noted that they've had at least one financial impact. So what is the view of caregivers in healthcare? Well, traditionally, family caregivers were seen as extensions of the medical care team, but not quite part of the medical care team. So what I mean by that is there was maybe an assumption, maybe that's not the right word, that once a family member was, going to be discharged from the hospital, that the family would be then taking care of them and taking on those care needs at home. But oftentimes that family member or that family group was not really included in that decision-making or in what that planning really needed to look like. And certainly not in getting the appropriate training that was needed to provide that care. The more recent perspective is that family caregivers are certainly individuals and people who need their own support and care. And that also family members may or may not be ready, willing, or able, or any part of that to provide care. They may be very willing, but are they really ready and are they truly able? So I wanted to touch on this because I think it's important to know that when I think about it, I've only been working in this area, this important area, for just a short time. But I know that there's been advocates, many who are in this room right now, for many years. I mean, change and addressing needs, we know takes a long time, and advocating for any very important issue just takes time. And so I like to recognize that there's been a trajectory here, and I'm happy to be coming in on the heels of all the hard work from those that have done this work. But starting in 2012, there was a home alone. There was a study done, family caregivers providing complex care, and it was really a landmark publication, and that was funded by the John A. Hartford Foundation and written by AARP's Public Policy Institute and the United Hospital Fund. And really what they found was some of these statistics we were even, looking at. They started with showing us and making us realize that 3 out of 4 family caregivers are providing medical tasks like managing medications, including IV medications and injections, and that more than half of the family caregivers who provided these medical tasks felt they didn't quite have a choice, and that they didn't think anybody else could do it, or there was no one else available to do it, or insurance wouldn't cover another option like professional care. So they also felt that, or many of them reported that they also believed that helping their family with being able to provide care in the home was really preventing them from being institutionalized, which is very important to many individuals and families. And then in 2016, you may be very familiar with this already, but that's when the CARE Act was enacted into law, and I'll say into law for Illinois. I would say it was probably over a period of time where most of the states that are engaged in it, which is 43, although I think Georgia now is 44 just recently. But so it was right around 2016, 2017 for most of them, right around that time period where it was enacted into law. And the CARE Act really required hospitals and health systems to do 3 things. They're supposed to be asking the patients for, if they have a caregiver, what's the name of the caregiver, and it's supposed to be recorded in the electronic health record. They are supposed to inform caregivers about impending discharge. They're also supposed to offer training, and very specific training to caregivers on the care that they will need to provide at home. So these are really important requirements that seem like kind of if you want to say like a no-brainer, that should be happening. But really, I was on a conference recently, and I wish I could tell you exactly who said it, but what I heard was they were talking about the CARE Act and where we were at with it, the compliance of the CARE Act. And it sounds like nationally, we're still really struggling with compliance in this area to a large degree. There's probably some areas that, but maybe even system-wide. And I think I can say at Rush here, are we system-wide, doing this, 100%? I don't know if we could say that, so it means we just have, more work to do in that area, and that change takes time. And the other part of this is that this particular law is not really at that point where it's being monitored or audited. So it would behoove all of us, though, of course, in the healthcare systems to really get a jump on this and really try and be compliant and mindful of this before it actually starts getting tracked and audited. And then in 2016, the National Academy of Sciences put out a report that engaged leaders in family caregiving that called for transformation policies and practices affecting the role of families in support of the care of older adults. And they really kind of focused on the need for dissemination and funding for evidence-based caregiver services. So that kind of started leading the way for us at Rush to do the work that we do, which I'll talk about in a minute. And then just to mention that in 2017 through 2019, we started engaging in becoming an age-friendly health system. Very proud of that involvement in the work that we're doing here. And we are committed to Care Excellence site. 2019, Home Alone was revisited. Very similar statistics were shown, a lot of confirmation on the previous report about the medical tasks, the level of caregiver burden and such, with additional information provided and recommendations. And then more recently, I'm sure most of you are familiar, or all of you are familiar with the RAISE Family Caregivers Act, with the 26 recommendations that were provided from the Family Caregiving Advisory Council. And that's really exciting. And we're very connected to that work and are going to continue to advocate and stay connected on how we act on those recommendations as an agency and as an part of an advocacy group. And I just want to maybe stop for 1 minute or so to see if there's any questions so far before I kind of go on with talking about some of the common challenges for caregivers. Okay, if there's no questions at this point, I'll forge ahead. But please, if you have a thought, please raise your hand or put something in the chat. Happy to be interactive with you on this. So common challenges for caregivers. This may also be very kind of something that you're very aware of, but I think it's important to note that what we see quite a bit is, there's levels of anxiety, depression. There's often cognitive impairment, not often, but that's can be a factor. And then medical illness of their own health and well-being. And then coupled with that is, we're seeing a lot of economic insecurity with cost of care and the additional burden of managing and supporting a family member's care. So we talked about this a bit, complexity of text. So 50% of caregivers performing complex medical care. And I'll just add or share that I was a family caregiver. I am currently a family caregiver, but when I was helping with caregiver for my dad, who had a cancer diagnosis, and he received his chemotherapy treatment and really had a very adverse impact from that. I mean, it was helpful in the long run to a certain, but he had an immediate, very intense reaction to it. And it really impacted his health, wound up in the hospital, etc. And so home care involved administering medications, but with IV medications, which I had never done before. I had no experience at all. We had all kinds of medical equipment then that had to come into the home, including oxygen, which I know for the medical staff, seems pretty straightforward, but for somebody that's really new to those things, and I remember a little bit of the information that I got, I was already so emotionally kind of distressed about my dad's condition and what does this look like and how's this going to go. As I'm getting this information, I'm hearing it, but I didn't know how much I was actually retaining. And I heard these levels, are critical and this and that. And it just was very, very distressing. And then my mom was with us was also helping with caregiving. We were co-caregiving, but she was really relying on me to a certain degree to hear this information because, of course, her level of concern was really up there too. And I can attest that no one asked us if we were ready, willing, or able to provide the care. We felt the same way. Of course, we had to do it, and we wanted to do it, but not sure we felt we were ready or able in that time period. So stress and burnout. So caregivers have been shown to have higher level of stress than non-caregivers, and that caregivers with chronic stress may be at greater risk of cognitive decline. So that's when we showed that that's where that impact can come in. And it's, no surprise where it might be coming from, managing those multiple roles, and then the adaptation to the new roles, and then the ever-changing complexity of a medical condition and in-home care, and even the older adults' feelings about declining. It's all in there. And, of course, isolation, if you're providing a certain level of care that really prevents you from leaving your loved one for any length of time, and then the physical demands that come with care. So we kind of talked about this. I'll just mention that, 40 to 70%, I thought this was important to note, that of caregivers have clinically significant symptoms of depression. So that's a high level to be, to consider and be aware of. And again, if we're not having those conversations or asking caregivers how they're doing, we're not going to know that that's what's happening for them. And we're not going to be able to support and address that. And I'll just add with this that, it also shows that there's higher rates of substance use with caregiving. And that just really comes with oftentimes, kind of trying to self-medicate, if you will, some of that stress, anxiety, etc., that comes along with a new role or a role that you might not have been quite prepared for. We talked a little bit about I mentioned social isolation, but I think it's important to note that caregivers of homebound older adults reported 44% rate of social isolation. So that's really that piece of, depending on the situation, and all caregiver situations are different, but there's a commonality there that depending on the need, the type of care that's needed, social isolation can really be quite a high rate. And then, of course, if the years of caregiving go on, it just increases the sense of isolation. Social determinants of health. I know you are all familiar with that, and we all know how that impacts, the social gradient. Lower socioeconomic status generally leads to increased health problems. This has to do with equity and the disparities, and that needs to be considered and addressed in all the work that we're doing. And definitely screening and asking about social determinants of health. So we do take a strength-based approach, and that's, of course, important in all the work we do with older adults, with everyone. With caregiving, it's important there's a lot of challenges, and there's a lot of information on the challenges and the stress and the burnout, but it's really important to consider and talk about. This is kind of that what matters piece. It's all what matters, but really honing in and kind of soliciting and engaging in those conversations of the meaning and purpose of caregiving for that individual, and leaving allowing space to talk about what that means culturally, how that feels, as a family, and why a caregiver might be in that role as opposed to other family members, and the dynamics of that. And really just looking at, the caregiver that you're working with as a whole person, and caregiving being one of their aspects of who they are and what they need to be addressed. So thanks to a generous grant from our Foundation for Aging, I mentioned them earlier, we did develop a program here at Rush to focus on support caregivers. And this is, of course, we're an age-friendly, so it's all about age-friendly health system. And that's our framework as we move forward in all the work that we do with patients and caregivers. And specifically with caregivers, we wanted to make sure that we were addressing how caregivers are identified, and that we are entering and included them in the record. So that goes a little bit back to the CARE Act as one, piece of that, right? But we look at this system-wide. So not just in the inpatient, but, best practices to do this system-wide. And really it's about identifying caregivers, because we can't, as Alice mentioned, assess and act on unless we're identifying who are the caregivers, what roles are they playing? And the difficult thing is too, let me just mention that not everybody identifies as a caregiver. So that gets a little tricky. We use caregivers when we talk because we kind of have to name something to be able to talk about it and really, get into, that discussion. But, we hear it all the time. Someone will say, I'm not a caregiver, I'm a daughter. I'm not a caregiver, that's my husband, or, that kind of thing. So that word caregiver doesn't always resonate. So we also have to consider other ways to ask those questions. Are you providing care for someone? Is somebody providing, if you're talking to an older adult, is there somebody that provides you with any assistance or support, that kind of thing, so that you're not just using that caregiver that, many folks might just not even identify with. And then the second aim of our work is to provide services and supports for family caregivers that really focus on their physical and emotional health and well-being, and approaching it from a what matters framework. So I just touched back on the CARE Act because really it's just kind of all tied in there that, we want to identify caregivers. And part of that would be, when somebody's hospitalized, to ask that care recipient, whoever it may be, if they have somebody that's providing care, so that we can start really, identifying them, supporting them. And that, as you'll see as we continue, we want to connect the fact that, are we asking if they're ready, willing, and able, and are we giving them are we supporting what they need for themselves, and also in care provision for their loved one. I won't go into that right now. And I'm going to skip through this too, because I'll be able to explain it in the next slide. So this is just a pictorial of, we feel that, of course, when caregivers are able to address their own and their loved ones' well-being, we feel like that there will be reduced levels of depression, anxiety, caregiver burden, and increased self-efficacy. And we see that happening two ways. First of all, we need to recognize caregivers. So that's one piece. And then the second piece is, of course, providing support, which is Caring for Caregivers program here at Rush. And so we talked about identification and documenting, and that's another piece. So identifying, but also documenting. So where is that caregiver documented in the older adult's health record? Is it easily noticed? Can any provider find that easily, or do they have to weed through notes? That's not going to be very helpful. So that's another piece to consider. Is it easily identifiable? Because we've gotten feedback that how we have it now identified, and I'll talk about that in a minute, it's been just very helpful, so that any provider at any time, it's right there, it's very highly visible, and they are able to make contact much easier, and it just streamlines the process for the providers. And then, of course, we want to identify the strengths, assess needs, and provide supports and services. And we do that with 3 specific components that we have available in the program that we offer. But first, I'll say that we get our referrals from inside and outside of our healthcare system. So we are definitely working with caregivers that are, connecting with the Rush Health System, but we also it's open to the community at large. So anybody that, reaches out to us, we will work with to support them. And we definitely address readiness, willingness, and ability of that caregiver and talk through that with them to see where they're at with that. And then we want to understand their emotional, physical, social support needs, so that we can really hone in on their individual situation and needs, very person-centered, very individualized. And I will say though, when you think about, connecting with caregivers, it does often take up to 3 calls or more to really, reach out to them, and sometimes to schedule when we are trying to assess and engage. And that's one of those things where it's a little bit of a rock and a hard place kind of thing, where caregivers have such intense roles or intense schedules that they often feel they don't even have time to take, to care for themselves, to get the support they need to actually balance better the work that they're doing or the role that they're participating in. So it's that little bit of a tricky thing of trying to catch them and engage with them when you can, and really being on their time frame and schedule. So we do a host of assessments with caregivers, and this is how we really hone in on where they're at. And you might be familiar with definitely PHQ-9 and the GAD-7. We also do a burden scale for family caregivers. We do screen for health literacy to adapt how we work with the caregiver, social determinants, health, of course, and we check for self-efficacy. And we do a very comprehensive biopsychosocial spiritual assessment. So we really get a full context of who they are, what matters to them, and how we can move forward in supporting them. And I'll go through these components that we provide, and then I'll open it back up to questions, because sometimes this needs additional clarity or there may be questions around this. So what we do after we provide those initial assessments of their strengths, needs, and what matters to them as a caregiver, we offer these 3 various components, and they can engage in 1 or 2 or all 3 of them. We also provide additional referrals as needed based on their individual situation. But I can say that kind of a very high percentage of the caregivers that we provide services to have engaged in the planning for what matters sessions. And we haven't named that because really that's what it is. What matters to that caregiver, and really what matters to the caregiver in their role as, and their relationship with the care recipient. And we often try to bring them in together as a dyad. It doesn't always work that way. And again, we let the caregiver take the lead, because this is somewhat designed to support them, because there's really no other support. As the older adult is the patient, if you will, they are getting kind of, their needs met, where the caregiver is not really having something focused completely on them. So that's really kind of our plan. So the planning for what matters sessions are up to 4 to 5 sessions where they meet with a social worker or advanced practitioner to identify what matters to that caregiver. We wind up hearing the context of their caring situation. We hear about the family dynamics. We hear about the relationship between themselves and the care recipient or the older adults. And we really work with them in to plan for their current needs, their current well-being, and then starting to plan for what will that look like as moving forward based on diagnoses and familial situation, caring situation, and really work to help them plan for their own health and then caring for their loved one. Skill building meetings are basically that multidisciplinary team that we're really talking about with age-friendly health. And this is basically referrals to these very valuable providers, PT, OT, pharmacy, dietitians, social workers. And that's really based on some of the things that even Alice was talking about, you know, a lot of, medication consultation, or, how does that impact, I mean, their understanding as a caregiver, like understanding medications and what kind of impacts that might be having on their caregiver. We've had caregivers that are doing transfers for their, in and out of bed or in and out of wheelchair, what have you. And, may say, I've been doing okay with that, but, recently I feel like I'm feeling a strain in my back. I don't know if I don't know if I can keep doing this. So, there could be referrals to PT for their own health. It could be OT for learning how to, really manage functionally doing a transfer where they're not going to harm themselves, etc. So these are really meant to be referrals and connections to other providers that can help build their confidence in the care that they're providing for their loved one. And lastly, we have care team planning meetings, very similar to like a goals of care meeting, where we just get the members of the care team, the primary, the specialty, possibly home health, the caregiver and the older adult, and really talk about getting on the same page with the goals of care and what, where they're at, but really with what matters to that older adult and including the caregiver. So it's all focused on what matters and making sure that that care is being addressed through a what matters to the older adult lens. And I'm going to stop there before I go into my outcomes, because I want to make sure to see if there's questions, as I've kind of been floating through this fairly quickly.
I'm sorry, Diane, did you open up for questions?
Yes, please.
Wonderful. Well, thank you so much. Wonderful presentation again today. It's been a really, really great day. I have so many questions in general, but maybe I will limit those for later. Right now, I was just very interested in learning. I heard a lot of referrals. You called the people 3 times. There's a lot of process and system involved in the care support that you provide. So I was wondering if you are using any particular digital platform to make those connections, communications, tracking, etc. Because I know that navigation and care support can get a little hairy in that way.
That's a good question. So we do use, and we've had a really, we've kind of gone through a process with that. So we've used a quality improvement lens as we've gone through this, and certainly done a plan, do, study, act process with, what's working, what's not. I think we're still kind of working through that, but we do record our outreaches we use Epic. Epic is our electronic health record. So we use that to track reach out, because here, let me say this, the caregiver becomes a patient for us. So I didn't say that. So, the caregiver, once we engage and they're interested, they become a patient for us. We generally open up a health record for them. They don't have to get any other services here at Rush. They may have their own services, but engagement in our program here, we do put them in the electronic health record. So then we do use that as a platform for recording our outreaches and tracking progress and all the assessments we do, etc. We also, though, use a tracker system, and it's basically an Excel sheet, but we use a SharePoint, so which a little more secure, very secure environment. And so we do have a grid where we collect and track data points, which includes how many outreaches, when, what was the outcome, that kind of thing. And really for us, that's just to continue to consider, other ways that we can reach out. Are there other, areas of engagement or ways to engage that we're not doing, or we should consider, so we can just kind of always look at, how that's going, and consider, how long is it taking to really engage and that kind of thing. So those are kind of our 2 internal trackers. I don't know if you were also asking if we're using digital to connect with patients. We do certainly have some caregivers that like to communicate via email or texting, but, and we offer virtual and telephonic as far as our intervention goes, but nothing really beyond that as far as like a digital engagement with our caregivers. I hope that answers your question.
Yes, thank you so much.
Sure. And is there any other questions before I move forward? I want to make sure I kind of just talk a little bit about these outcomes here. And we certainly will have time for questions at the end too. So I'll just kind of go through these quickly so we do have time for everyone's questions. That's the important part. So this is just to show you that we, our data as far as change in depression and anxiety and caregiver burden. And I'm sorry, give me 1 second here. Okay, so you'll see that we did see reductions in depression, anxiety, and caregiver burden that are statistically significant. And again, we used, the PHQ-9, the GAD-7, and then the burden scale for family caregivers. And I think what's important to note is that, we saw that the levels of depression, anxiety, and burden moved from a level indicating the need for intervention to levels that indicated that no further intervention was needed, which is, a really good outcome. I will say that this is based on our initial assessment, which is 1 month after the intervention, which is that planning for what matters, or some of those other components have been completed. Then we do a 1 month post. So what we are seeing, we are also doing a 3 month. We're not seeing is the outcomes are starting to not look as good, or they tend to go up a little. The anxiety tends to go up, burden can sometimes fluctuate in the other direction. And we also do a 6 month assessment, but we have, low rate of success in reaching out and getting the 6 month data at that point. We do the outreach, but it's very difficult to engage folks at this time. And we're working on considering ways that we can improve that. I wanted to quickly share this and realize I should have put it in a different format, but I just thought it was really nice to see the words of a caregiver and what her reaction is. So I'll just let you take a few seconds to read through that. And I really wanted to share this because it's similar to comments that we hear from many of our caregivers, whatever the situation is. And I think that was something, like I said, Alice led with, about listening. And we hear that quite a bit from our caregivers when we start asking some of the questions, like about how they're feeling or about their caregiver role. They're like, oh gosh, nobody's ever asked me that. And we even hear things like, I've been doing this for how many ever years and nobody's ever asked me that. And sometimes we hear including other family members. So, it's really, it's just really critical that we offer that support. I wanted to show this video, but instead I'll share it in the chat because it's not working. I tried it earlier, so I apologize for that, but it's really just another little testimonial. And this was just such a dear caregiver that we worked with. And he actually posted this and provided this to us just shortly after his mother-in-law passed. And it just, kind of talked about how it really helped him because he just really wasn't ready for that caregiving role and just didn't know where to turn or what to do. So if you ever get a chance, it's just a 2-minute video, you'll get a chance to look at that. And then I included this quote because I loved this caregiver that she talked about being grateful that we had her take those little quizzes, which are the assessments, the questions. And again, she just notes that she hadn't thought about herself for a long, long time. I'm sharing this quickly too. This is some information that we pulled about our care recipients, so the older adults. So for caregivers that were involved in our program, we pulled data from those older adults that they cared for 6 months prior to engaging in our program and 6 months after. And we are very clear that we can claim no causality at all here. But it was just something we wanted to initially kind of pull and kind of take a look at. And we did see significant reductions in ED visits, inpatient admissions, and length of stay, which just says because of this drastic reduction that, it's probably coming from many factors, it just tells us that there's potential there for us to take a deeper dive and take a look to see if we're really having an impact. But even if we took these numbers and really reduced the significance, we would still have something positive to consider here. So that's very hopeful, and we're going to be doing more work in that area. Alice mentioned the Capable program here at Rush, and I'll just say that's included here in my list of programs that we have offer here. And this is not a comprehensive list. I just didn't want to make the slide too crowded. But we do try to consider when we work with caregivers and older adults and being age friendly, we're just, what are all the potential services? Because not one size fits all. And we want to have a variety of things that help with the 4Ms, with mobility, with medication, with, and then the emotional management factors, being socially isolated. Let's, have a friendly caller program. So there's lots to offer as far as wraparound services. And I think that's important in any age-friendly health system to consider what other options you can offer. And quickly, I'll mention the Capable model here at Rush. That we are really just getting started, but so thrilled to be doing this work. I spoke with our program manager just the other day, and she shared this flyer. We are focusing on the west side of Chicago at the very underserved section of Chicago, and Rush is situated in the west side of Chicago. And really that's our community. It's one of our communities, a very near and dear. And so we are focusing on that to support those homeowners 62 plus in those home modifications. And we'll have more information to share very soon. And just like Alice mentioned too, we are trying to also, publicize and, advocate and get the word out and inform and connect and collaborate. And that's just a plug for E4 Center for Excellence. And that's my end of my presentation. I'm so happy to also answer any questions, or if you need to reach out, please do so. There's so much information, and I'm sorry that it felt maybe a little rushed, but I could just talk about this for a couple hours. So anyway, thank you so much.
Thank you so much, Diane, for your wonderful presentation. We do have a few minutes left, so are there any additional questions for either Diane or Dr. Bonner? And you can unmute yourself to verbally ask your questions.
I'll make a point. It's not a question, but again, I just want to make the point that, Diane and she has wonderful colleagues who work with her at Rush. Some of this stuff is really hard to start, but they just do it. They just say, okay, today we're going to start and we're going to do X, Y, or Z. And it's not easy in the beginning, and there's challenges, and people are naysayers and say, oh, you can't do it because this, or we tried it before and that didn't, we all deal with that, right, all the time. And so they just move through it. And there are organizations that are successful in part because they get through those early stages. So I would just encourage everybody on the call, be that guy, be that person who just says, today we're just getting started. And then, you work through what comes along.
So true. I'll briefly mention, it took us a couple years to get a caregiver, a very specific, beautifully bold caregiver field, very clear in Epic. And that wasn't through the Epic people. It was a workaround through, a modification through our IT folks. But that just took so long, but we did it. And it's like such a thrill when you just got to keep plugging away. So agree, Alice. Thank you for that.
Thank you. I actually do have one quick question, Diane. I know you mentioned at the beginning of your presentation that I think it was either the patients or the caregiver, and I apologize that I am getting it mixed up, that they work with the nurse to do goal setting. Could you just briefly talk a little bit more about that, and if the patient, do they set their own goals, or are they given goals based upon their ailments? Can you just briefly talk about that?
So yeah, I'm thinking that might be, so it sounds like with our caregivers.
Yes.
Yeah, so for our caregivers, so for nursing, anything with a nursing skill, we do tend to refer. We don't have like a nurse that works like in our caregiver program, so to speak. We don't have a designated nurse. We work system-wide. So our program is, available system-wide. So basically, if there's a nursing need, a nursing skill need, or the caregiver needs to develop some, like, again, the IV medication, like some skill building, we really connect with the older adults care team to see if, how we can arrange for additional skill building for that caregiver. Sometimes it involves home health. Sometimes it just involves, either the primary or the specialty care team for that older adult in providing just that increased confidence. I didn't mention this, but we are currently testing our model, this model in other age-friendly health systems through that generous funding from the John A. Hartford Foundation. And so we're going to be learning from these various sites who have different settings and different care teams in different involvements. For instance, we have a couple of nurse practitioners that are actually providing the intervention rather than like we have a social worker doing it. So we're learning how wonderful it is to have a nurse practitioner completed that intervention, because I just spoke to one of them the other day. She just said she was able to just jump in with that skill building and talking about like medication consultation in connection to everything else that caregiver needed. So we're exploring how does this work best in different settings, and what's the adaptability for this model to address those needs most efficiently and effectively. So hope that answers your question.
It does. Thank you so much. And we do have a brief evaluation for today's session, so we would appreciate it if you could take the time to complete the evaluation either by scanning your phone or your tablet and on the QR code, and we will also drop the evaluation in the chat as well. And next week, we have another dynamic presentation about the challenges, barriers, and solutions to actually implementing the age-friendly health systems framework. So we talked today, you just heard Dr. Bana encourage everyone to get involved. So if this is something that your organization has been looking to do, next week's speaker from New York will actually give us some insight into what they did across the state to implement the 4M framework in their health systems. So thank you all so much. And again, here is the contact information for our speakers from today. They are very receptive, and they did ask that if you have any additional questions, to please reach out to them. We will send a recording of today's session next week, so you actually get to hear it back and hear all the questions that were answered and some of the resources that were included. And we will also email the links that like for the conversation project and some of the reports that were included in today's session. So thank you all again. And I just want to thank again Dr. Bonner and Diane for both taking the time out of their extremely busy schedules to present today, and for the phenomenal work that they are doing across the country. So we thank you so much. We appreciate you. You are wonderful. And thank you all for taking your time out today to join us for this session. So have a wonderful day, and we'll see you all in 2 weeks.
Thank you.
Thank you.